All right. Good afternoon, everyone, and thanks for joining today's session. My name's Jamie, and I lead our client success team here at 3Terra. With the help of Ian, Matt, and Lisa, we'll be sharing how DQA clients have used 3Terra support services to extend their DQA platform. We'll be recording today's session and sharing this with all of you afterward. But to assist with recording quality, we do ask that everyone keeps their cameras and microphones off. We've also set aside time towards the end for a brief Q&A, so please drop your questions in the chat at any point. And if we don't happen to get to everyone's questions, we will follow up with you directly afterward. 3Terra Support Services is one of the offerings available to add on to your fiscal 26-27 DQA license. It's tailored to meet your hospital's needs, and these hours can be used organization-wide. They're flexible and they can be repurposed as new items come up through the year as well. So today we'll be sharing how hospitals have used these hours to enable new data quality checks, enhance their reporting capabilities, and also support their people. To get us started, I'll pass it over to Ian.
All right. Thank you, Jamie, for getting us started. I'm Ian Robinson. I'm the leader of the product team here at 3Terra for DQA. And I'm going to talk to you about how you can use these support services to expand your data quality coverage. And when we say expand data quality coverage, what does that mean? DQA provides a robust library of data quality checks, but it doesn't cover everything. Hospital coding departments still have manual audits that they perform each year, or there's data they'd like to use for checks, but they don't have the time or resources to turn those into reality. And there's an enormous amount of additional information that we can use to create checks to reinforce coding accuracy and have a real impact on weight, funded volumes, conservable days, and hospital performance indicators. So how do you expand data quality coverage? Well, these additional checks broadly fall into two categories. The first is reconciliation. We've got something in the hospital to use. We use it as evidence to check against our coded records and verify that that's there. The second is a true data quality rule where we use logic, standards, or other records to create rules and highlight and bring cases to your attention. So if you're a hospital or health records department, you're probably asking, okay, where do I start? I'm going to walk you through several examples of what we've done with hospitals in the past year that have generated tangible results to kind of prompt you to kind of think about how this might apply to your hospital. So the first case study I want to walk you through is about GI endoscopy procedure mapping. We all know GI endoscopy is a complicated funded volume. The criteria is complex. And a hospital reached out to us, they wanted to make sure that everything was being captured correctly, that they weren't, things weren't falling through the cracks. But they ran into a couple of problems. They didn't have the time or the people to do the mapping, to map their, the procedure codes in Meditech to the final GI endoscopy categories to do a reconciliation. And even if they had, it would mean adding a bunch of burden to their staff. Like one more thing to do at the end of each month, it would be a time-consuming process, and then you have to upload it to DQA in order to make that happen. So we engage them with a support services contract in order to kind of come up with a solution together. So what was that solution we put in place? The first thing we did was we built a custom import to bring in their procedures just as they exist. So no transformation required at all. Whatever they got out of Meditech, we pull right into DQA. So rather than the hospital doing the mapping, we then created a mapping from those procedures to the final GI endoscopy index categories required, worked with them to validate and make sure that they were correct. And then using that mapping, we created checks that highlighted cases and brought up the things that might be falling through the cracks or should be reconciled. And then in order to minimize review time and improve that data quality flow, we also created a viewer in DQA that presented the actual procedure data. So this way, while we're doing review, the coder doesn't always need to go back to the EMR and check. They're able to adjust the record using the information just presented to them in DQA. This is always something we're aiming to improve to minimize the amount of switching between systems that has to be done. We know that's a constant pain point. And so we're always trying to improve how we can present the information that we're pulling from other systems to in DQA. And then lastly, we created a report that gave the hospital direct insight into how many procedures they'd actually recovered through these new reconciliations. So how did this work out? The total investment was about 40 service hours. In exchange for that, they have confidence that things aren't falling through the cracks. They were able to recover a meaningful number of GI endoscopy procedures in the process. And moving forward, they continue to have that confidence that things are being captured correctly. And when things come up, they can work, coders can work together to identify how they can improve their process to make sure things are improving in the future. But the theme that I want to present here is that if you have data that you think can be used for data quality, you don't have to provide us with a mapping. That's something that we can help you accomplish, and we can work together to come up with the solution there. And I've got a couple more examples to go through that I'm going to do a little bit more quickly to show a couple of different ways. So our second case study here is about ED time reconciliation. Another hospital reached out to us around, they were questioning the accuracy of their pay for results times following an EMR go live. The numbers were a little bit worse than expected, and they wanted to make sure that everything was being captured and recorded correctly. So what was the solution that we came up with together? We directly imported their ED times out of the EMR. Similarly presented the viewer in DQA so they can see those ED times out of the EMR in DQA, again, trying to remove the switching back and forth between systems. And then we created checks that respect a difference threshold. So, if the difference is 1 minute, maybe that's a lower priority record to review, and then something that might be different by 20 minutes. That way we can allow them to focus on the larger impacting changes first, similar to what we do with our existing data quality checks. And again, so how did that work out? That took about 12 hours of effort on our part through the support services. We were able to integrate this new reconciliation of ED checks into their normal data quality review. So we've eliminated the manual effort that they were going through to reconcile, disposition times against the coded records. And we reduced the thousands of discrepancies that exist that might be off by 30 seconds or a minute down to the few that were larger and impactful so they could focus on those. And now moving forward, they have confidence that the pay for results numbers are correct. There's no coding quality impact that leadership has to take into account. It's all just those are the straight numbers. Lastly, we know that most hospitals, even after a DQA implementation, will have manual audits and rules that they're using. They're generating lists and distributing cases, following up and validating the changes. This is a time-consuming process that all health records departments know well. So this is an example where a hospital reached out to us kind of with something like this. They wanted to remove that manual effort from their annual flow. So the problem that they faced was, not every endoscopic procedure was being coded in the correct location, and they were presently tracking this via one of these manual audit lists. So the solution for this was pretty straightforward. We talked to them, identified what the logic was, understand what cases they wanted to get brought to attention, and we built a custom data quality check into DQA that just identified those records so that they could flag those for review. That was integrated directly into existing DQA reports, so they just show up along normal data quality review in DQA, and then they can complete it that way. And this is something that's pretty straightforward for us. We've done this a lot. It took about 3 hours of time. And the result is that now that there's a backstop, their data quality concern was addressed. And now they have the ability to, one, identify when this is happening and how they can improve their initial data quality. But they've also got that backstop to catch something that falls through. But it's also just part of the DQA process, part of the normal workflow. There's no more manual audit list and following up with people on whether those checks got resolved or not. So ultimately, when we're expanding data quality coverage, there's a few themes I wanted to bring to attention. Like one, we can do the mapping for you. If you've got data that should signal important things for you, then we can help do the mapping if you don't have one that existing or don't have the time or resources to build one. We can also transfer many or most of your manual audits or things that you think are ideas quite quickly, so you can leverage DQA even more in your data quality efforts and remove the number of individual reports and audits that you're doing. And lastly, if you have dreams of more data quality, let's talk about them. We're interested in wild ideas about what we can do together. There's no commitment to having a discussion with us about any data quality improvement. Please reach out. Let's talk about whether that works, whether it's feasible, and how we can make that reality. So next, we're going to move to the next section about analysis. I'm going to pass control over to Matt.
Great. Thanks, Ian. So what I'm going to talk about is how hospitals have enabled deeper analysis and deeper reporting, custom reporting, by using the support time as well. And so, as I'm sure most of you know, DQA provides a lot of calculations and data out of the box. Specifically, it does things, that are common to all hospitals, like calculating your QBPs, your wait times volumes, your mortality rate, your harm, and various other things that I've included here. And this is just a screenshot from our website where we list all of the different indicators that we maintain on your behalf. But your hospital has ways that they look at data that's different than everyone else. This applies when you're the same as everyone else, but you're not the same. There might be specific initiatives that you're working on, specific metrics that your leadership team is monitoring, that don't apply to everyone else. And in those cases, you kind of have one of two options. Either your internal decision support team can implement it and maintain it going forward, or you can reach out to us and say, we'd like to have this implemented in DQA. Can you do this for us? And this is becoming more and more prevalent for us because we're seeing that decision support teams are stretched further and further. You might not have the time, the resources, to be able to do this in a timely manner. And that's where we can kind of step in and help. So there's kind of two common ways that we've helped to date over the past year or two. Implementing custom patient populations or implementing custom indicators are kind of the two broad buckets, and I'll give some examples of each. Mental health analysis has been really prevalent in the last little while. It's kind of a common area of analysis. And so we had a hospital reach out maybe about a year ago, and they said, they wanted to implement a mental health cohort. And I kind of said, well, this would be pretty straightforward. We can just look for all the F codes that represent different mental health conditions, and we can look at them either from most responsible diagnosis or present anywhere on the record and say, this is your mental health population. But they kind of said, hang on a second, that's not quite what we're after. We have a specific, definition that we want to use for our mental health patients. We've, done this before, and we, look at our patients a little bit differently. What they said to us was, we have to identify which mental health patients have substance use involved and those that do not. We want to be able to differentiate and report and analyze those two differently. So we've got a bit of a different dimension there. And not only that, the codes that we want to look at here are a little bit different. We have some T codes that we want to include, and I think there were some Z codes, some of the F codes they want to exclude. So their definition was truly, unique and different than kind of what a standard mental health cohort would look like. So what we did is we worked with them, we found out their requirements, we quoted out how much time will this be to implement this. And it wasn't a lot, maybe it was, a half a day or a day worth of time, but something that their decision support team wasn't going to be able to get to, with the backlog of work they had for, a number of months. And so we implemented a, mental health cohort definition directly within the DQA database. And what this meant for them is that they could use reports in the platform to create standard reports for their leadership team so that they could self-serve on these sorts of populations. And they could also do ad hoc analysis directly within the tool. On their roadmap was also to build out Power BI with the technology of choice for them, Power BI dashboards. And they wanted to have a data source so that, in a couple of months when they were ready, they could build analytics off of this. And that's eventually what they did. They pointed Power BI to our database and began, doing ad hoc dashboards within the tool. And then down the line, they want to establish a data warehouse. This is something that, eventually they will, pull data directly from DQA and use it as a source, a new data source for a custom definition that they can just maintain as a single source of truth going forward. Obviously, this isn't unique to, mental health populations. Any custom population can be implemented in the same sort of a methodology. One that comes to mind that we implemented a little while ago is readmissions. Everyone looks at all cause readmissions, but it's more meaningful if you have a more nuanced definition of what's a related readmission. We worked with a hospital a couple months back to essentially implement a narrow definition that they had and had refined over time so that they could use it in a similar way. From an indicator perspective, there's indicators flying around the hospital all the time, whether it's HSAW indicators or QIP indicators, custom indicators. Oftentimes these are things that need to be implemented and maintained. So we'll often get, requests to implement HSAW indicators. We've got a new indicator that's going to go on. We want to be able to track it through DQA, just like we do for other indicators that are on, the HSAW. Can you implement, as an example, what was the last one? Repeat unscheduled ED visits within 30 days for substance use conditions, I think was, one of a recent request that we did. The same is true for a QIP indicator. It doesn't even have to be based upon coded data. And I'll give maybe one final example there. We bring in critical care information system, CCIS data, into the system to support with data quality work. Last year, there was a hospital that reached out and said, well, you already have that data, and we would like to do some measurements, some resource intensity measurements within the ICU based on CCIS data. And so, we had a conversation. What would we need? What would we need to bring in? Ultimately, we brought in some additional CCIS outcomes data, exposed it to them in the database so that they could self-serve and build the analytics that they were hoping for without having to kind of invest in the infrastructure. And so, in all of these cases, it's about, the DS team or the analytical team not really having the time or the capacity to be able to handle things and want to have it integrated with the reporting that's already available in the tool. So, we can implement things like this in all cases. When you engage us in a conversation, we essentially, scope it out with you, work with you to determine, what type of time and effort it will require, and then move forward and implement, often within, a couple of weeks or a month. So it can be done pretty quickly and as you need it. Jamie, let me pass it to you to talk about how we support people.
Great. Thanks, Matt. So many of the support requests that we receive come down to the same thing. Teams are resource constrained. In addition to expanding data quality checks and reporting, we're helping teams navigate pressure and make the most of limited time. Sometimes that support is short-term, like when a team is behind with year-end fast approaching, and they need help figuring out where to focus. Where other times the need is more about long-term capability. So for example, if someone is moving into a new role and needs structured support to build that confidence and take ownership of their work. So it isn't just about helping teams in a crunch, it's also about helping hospitals build more sustainable processes over time. So let's give you some examples of how this actually plays out in practice. A hospital came to us at the beginning of April. Some of their senior coders were on leave, they were still catching up on coding, and their data quality lead was pulled away to be part of their hospital's EMR project. Needless to say, they were pretty stressed. Traditionally, their data quality lead would assist with direction, but their team was trying to review everything, and they didn't really have a clear plan of what to do next and where they could have the biggest impact. So they were fairly overwhelmed. Understandably, their manager was concerned that this flurry of unfortunate events would lead them into an even deeper spiral. So they asked us for help. After confirming their hospital's priorities, we helped them build a targeted review approach, focusing their efforts on the opportunities that would have the biggest impact while also being cognizant of available resources. And not only did this give their team more clarity on where to actually focus their efforts, but it also helped them feel more in control because the work was more manageable. We were there to jump on calls when additional clarification was needed, and we regularly checked in to reinforce their progress. In the end, they recovered over 100 QBPs. So this was a huge accomplishment, of course, because they were concerned just a few weeks prior, but Also, it's important to note that they were no longer spending their valuable time trying to review absolutely everything at once. And this is just one example of how we've supported teams under pressure. But sometimes the challenge isn't necessarily volume, it's more about that change. So, another client hospital was preparing for the retirement of their long-term data quality lead. They had a strong internal team, but no one had ever led their data quality in that capacity. And what they needed wasn't necessarily a big consulting engagement, but they needed some structured, practical support to help that incoming team member build that confidence quickly. So, over the course of about 3 months, we met with them bi-weekly. We walked through targeted reports, reviewed their priorities, answered questions, provided some samples to take away, and helped them understand where to focus their efforts. And by the end of that period, they felt much more confident leading that work independently and supporting the rest of their internal team through that review. And it's important to note that this wasn't about us taking over. It was about helping them bridge that transition and build that long-term capability. But of course, not all support needs are always that involved. Sometimes the need is much smaller. For example, the Data Hub date range viewer was causing a lot of frustration for one of the data quality teams that we work with. By default, this date range has a 30-minute buffer on either end of the visit times, but they wanted it to match those times directly. No problem. Our team took it away, and within a matter of 4 hours, they were able to eliminate that aggravation and create a smoother workflow for the team. Across all of these examples, the common thread is helping teams make better use of limited time and resources. Sometimes it's helping focus review efforts so that they can have the biggest impact. And sometimes it means supporting that leadership transition, or sometimes it's just removing those daily frustrations. At the end of the day, support services is going to help hospitals get more value from DQA by making the work more focused, more manageable, and more sustainable overall. Beyond the examples that we've shared here today, enhancing your data quality, enhancing your reporting, and supporting your people and processes, there are a number of ways that you can use these hours. And we're here to help you tailor these hours to meet your needs. We always want to hear your feedback so we can continue to improve these webinars. So we're going to drop a link to our feedback survey in the chat here, and it'll also be sent out with the recording within about a day or two. We're about to jump into the Q&A, but while we're waiting for any additional questions to be dropped in there, let's talk about how your hospital can sign up for support services. So this is an offering that is available to add on to your fiscal 26-27 DQA license, and the hours can be used organization-wide. They're also flexible, so they can be repurposed as needed throughout the year. They don't have to be expensive, and we're here to help you determine the appropriate number of hours for your hospital. I'm going to hand it over to Lisa for the Q&A now.
Awesome. Thanks so much, Jamie. We're going to start taking questions from the chat now. Going through the chat here. Let's start with Majid's question. Referring to the GI endo data quality coverage from Ian's presentation, is this process available to Epic users?
Hey Majid, thanks for the question. So the answer is yes and yes. So yes, it's available for Epic users. We're working on doing direct integration with Epic, and we'll have an announcement about that in the coming months. For the moment, what we can do, which we have done with other hospitals as well, is just use the information that gets pulled out of Epic as is, like as it actually exists in what you do, such that we're bringing it in, presenting it to you in DQA, and doing all the mappings and like tying it to visits on its own. So the answer is yes. We'll just have to talk exactly about what that information looks like so that we can make sure we're addressing it appropriately.
Awesome. Thanks, Ian. We have one more question from Janet here. Is this procedure location dependent? For example, does the procedure have to be done in the main OR, endoscopy, or non-OR procedure like fluorocentesis and DI?
Thanks, Janet. So it kind of depends on what you're trying to accomplish. For the example that I had for GI endoscopy reconciliation, that was we pulled or the hospital provided everything that happened in their OR and endoscopic room, and then we were using the procedure codes that were in the EMR to map to the destination. If location matters for that reconciliation, then we can absolutely tie that location into the logic and mapping that we created in order to make sure that that's as accurate as possible.
Amazing. Someone else asked here, can some of these data quality rules be applied to our DQA?
Absolutely. Unfortunately, P03918, I'm not sure exactly who you are. If you can text us directly through Zoom here, or if you want to reach out to us directly, we can absolutely talk about what like some additional checks that we've worked with other hospitals on to see whether they could be applied to your DQA. In many circumstances, that's going to take very little time. For some things where we do have to do a mapping, we can give you an estimate about how much effort that would take.
Awesome. Thanks. And we have a question here from Perica. Have you done anything on hospital harm indicator from High? Apologies if this was discussed.
Yeah, I can take this question. Hospital harm is certainly something that we've worked with. We've integrated data from different systems across the hospital to identify like never events or harm systems. We've also done a lot of work more so in the analysis side of things to look at how harm impacts different things. So the cause and effect of harm, length of stay, conservable days are certainly part of that. So maybe worth connecting directly, Pete, if you'd like to talk about that a little bit further.
Awesome. Thanks, Matt. Thank you, everyone, for all your questions. And of course, as always, don't hesitate to reach out to one of us directly. But I'll pass it back to Jamie to close it off.
Great. Thanks, Lisa. And thanks everyone for the questions. That's awesome. Once again, any additional questions that we did not get a chance to get to, we will follow up with you directly. Just want to say thank you all for joining us here today. We will be sending out the recording and the survey link again, so please keep an eye on your email for that. And I just want to say congratulations to the winner of our $50 gift card for completing the survey back in January. So we look forward to hearing your feedback. We look forward to seeing you all again. Thank you all. Take care.